Hi, this is Dr. Burt Bowden. Once again, this is our Masterclass number 2. I'm going to teach you a little bit more about small incision cataract surgery. We haven't actually, and probably won't get much into the procedure this time to show you anything about how to do it. We're still learning about the whys and wherefores. And like I told you before, I want you to understand that I'm going to tell you what I'm going to tell you. And that's the idea behind these first couple of classes. So I'm telling you about how this is important and how to do things and why you want to know and have some of the basics. So first I want to tell you about how small incision cataract surgery is the same as phaco surgery. One of the things is that I do make paracentesis. I actually do two paracentesis, but the idea is with that you get a formed chamber as opposed to a video you might see online. It shows just one paracentesis and working through the main wound where the chamber collapses, and it's really tough to do. But if you have two paracentesis, that you have a formed chamber, and you do just like you used to with a phaco, or you're using that for the IA part also. But it's just like normal to begin with. So after you've made the paracentesis, then you put in your lidocaine, and I do continue to do this from the side. I do it from the start from the side. I do it with just lidocaine on the mission field. Of course, we frequently will do it with retrobulbar block. But the idea is that you do it with the lidocaine and just do what you're normally doing. If you have to change over and convert, then you can. If you start to begin with, you still sit at the side and you still do the intracameral lidocaine. Patients do fine with it. There's really no trouble at all. So once you've done that, then if you need to help identify the capsule more, you can use the trypan, although the capsulotomy is easy to do, which I'll talk about a little bit, the can opener capsulotomy, which is a little bit different. But if you need trypan, you can use that, and then you'll use the yellow. And again, I tell them to use the yellow because that's what is the easy way as you're teaching your technicians. That's the viscoat, and we'll fill that eye up to boy, I don't know if we're nice and tight to the viscoat starting to come out. And what that means is the pressure in the eye is really high, but it gives you a standard set feeling so that as you're doing the surgery and making your wound, you'll be able to make it very easily and everything will be the same. But that's different than the normal small incision. So in or normal phaco. So to get the lens out, we have to first get into the eye, and so we'll use the same slit that you had that you were doing the phaco with. We do have to add a few things, but I'll talk about that. So you'll do the hydrodissection, which is the same. You got to get it to spin. And Uday Devgan says if it doesn't spin, you can't win. So we want to make sure that it's spinning and free. And then you can get the lens out, and I'll show you some little tricks about that as we go along. But the hydrodissection is the same. You just bring the whole lens out into the anterior chamber. And then once you've delivered the lens, then you'll use two hand pieces or the Simcoe for the cortical removal. That's how it's the same. You're doing the IA basically the same, except you can't use your standard IA handpiece because it'll blow fluid all over the place as it will only go through the main wound. So that chamber is being tried to be maintained, and so it's going to just let that fluid in there like crazy, which then comes out like crazy. So you have to do two hand pieces or a Simcoe for the cortical removal, but the chamber is still formed. So that's why I left it under it's the same part there for the removal. So then you insert the lens. Of course, it's not folded, but that's the same procedure. Reform the chamber, insert any antibiotics. We always use some Vigamox at the end, um, so that we don't have to worry. And then there's no suturing that's required. So same thing as a phaco. That's the beauty of it. But it is different in that you need about 7 extra instruments and supplies to add to the case. And I'll have it in a handout that'll be available for this and how you can order these things also, so you don't have to worry about scrounging all around. But here they are. The basic idea is you got to have a bipolar cord to connect with a bipolar because you got to do some cautery. Now, I like to use the pencil tip cautery. You can use other types. The pencil tip allows me to just paint the sclera and then solve everything. I have some special forceps. The guy that makes them for me in Pakistan calls them the Bowden forceps. I don't like putting my name on it necessarily because some people really get excited about that. I even know Dr. Eisner who named a fat pad after himself. Who would want a fat pad named after you? Anyway, you also need the crescent blade. You'll need a lens inserter if you want. You don't have to have that, but you do need to have the takeout instrument, which is the irrigating vectus. You'll need that, and then you'll need those double uh, handed, so bimanual instruments for IA that you'll need. So 7 extra things that you have to do, and just have them sitting in a little box. And if the tech you ask them, hey, we got to convert, then they'll just grab that box and put those things on there, and it's ready to go. It takes no time at all once you've thought through how to do this. So small incision is also different because of the Westcott's and doing a limboperitomy. We have to do that to open up to get to the sclera to make the incision. So you have to be sure that you're right down onto the sclera. I also do use a took blade occasionally, which you may never have heard of. It's TOOKE, and that blade is important if you have to get rid of some of that extra tenons that's there. It works really well. Of course, if you've never done small extra cap surgery, you may not have ever used it. But the beauty of that is, as you use your scissors, you can take those Westcotts and roll that eye way down and get it into good position. And it just kind of gets everything a lot easier to do, a lot easier. You don't need any stay sutures or any pull down sutures, anything like that. Then you have to create the tunnel, and we're going to talk extensively about that because that's the main difference in a small incision cataract surgery. I want to teach you the 3 distinct steps, and you'll always get it right if you'll do these. That's one of the parts that's definitely the hardest for most folks. As you learn it, as you do it, it really makes a whole lot of sense if you understand what you're doing. And we'll talk again repetitiously, as repetition is the key to adult learning. We will teach you how to do those so extensively that you'll be saying the things in your brain. One of the guys I just worked with on another mission said that I still hear your voice saying to me, make the incision, improve the groove, and you'll know what that means here soon. So it's different because you also do that canoper capsulotomy. You can use a standard Rexus if you want, but the beauty of the can opener is it spreads out the forces, and so it never spreads beyond the equator. I've not ever seen that happen. It might go to the equator where you do the capsulotomy, but as you bring that lens out, it spreads those forces out across the whole lens and across that capsulotomy so that it just does not go past the equator. And that's one of the beauties of that. Now, you wouldn't want to do that in a standard phaco, but in a small incision, it's really nice. It's really easy. You don't have to have the trypan blue. And you can just do a standard Rexus if you want. But guess what? Then you go back to the same problems that you can have with the tear out. So a lot of times, if I have someone that really doesn't want to do a standard a capsulotomy or that wants to do a standard one instead of the can opener, I'll just say, go ahead and make like 4 little relaxing incisions in that capsulotomy, and then that will do about the same thing as a can opener does. It helps a lot, and so we'll talk more and more about that and why it's important. So once it comes time, then you got the lens spinning, then you got to get it out. That's really hard for a lot of people to understand exactly how to do it because you never tried doing this whole thing before. Sometimes it's just real easy, and I like doing one of my favorite ways is just flipping it out. So I'll just push on the pole and the pole closest to you, sometimes on the side, but anyway, the whole lens will flip. And the lens will flip, and you got it upside down in the anterior chamber. That's really easy. There's a whole lot of different ways, and I'll teach you about the ice cream scoop, how to use pressure on the side, how to flip it. You'll understand later more about what I talk about the pants over the hips and how to use the viscoat to push back the iris. All these things will become ways that you will learn and understand because that is one of the harder things to do. But once you've done it 15 times, then it becomes very second nature, and it's not hard at all to do that kind of thing. So I want you to understand that the small incision is different a little bit in the lens insertion only because we're putting the whole lens in. You don't have to fold it. I have a special lens inserter made by my same guy in Pakistan, and it allows you to use vertical grasping in order to put it in as opposed to a McPherson, which is a horizontal, which would make it a little bit more difficult. And I'll show you pictures of that and why it makes sense to do it each way. And again, I've thought through all of these things and decided these are the best ways. And when I'm teaching you, It's the way that I've learned after teaching others, and they go, I can't do this with these McPherson. Oh, let me show you. And it makes a lot of sense. So remember, I told you each time when I finish a class that there's some action items. So I want you to think about how we're going to do this, that you're going to speak the procedure in your mind. I want you to be able to say what you're doing. And a lot of times we do that with residents, ask them to try and say exactly what they're going to do. So it's very good to know the steps and speak the procedure specifically. And you may hear my voice in there some. That's okay, because I want you to be thinking of exactly what you're going to do, how you're going to do it, and remember the specifics. But the beauty of it is also, as you have it down and know it, you're going to be able to explain to the tech what you're going to do. And you'll teach the tech, you'll teach them how it's different, and you'll get them on board and ready to go. They'll be excited when you're ready to start doing this, because they'll know that you know what you're doing, and they'll be excited to join in with you on it. So that's the end of the second class, and there's a whole lot more to come. Thanks.